Hello, good afternoon, everyone. Thank you so much for joining us today for session number 6, our final session in the Food, Health, and Cultura series. We're super excited to have you with us, and we are thrilled to welcome our speakers. Our program director today, as you know, is Angie Romero-Neeson, MD. Dr. Neeson is a quadruple board certified physician who's passionate about advancing health equity by amplifying the expert voices in medicine, where health, nutrition, culture, and lifestyle medicine can intersect and advance chronic disease management in a culturally adaptable manner. Welcome, Dr. Romero-Neeson.
Thank you so much. All right, so now this is our final session. We are so lucky to have Dr. Rob come back to us, and he's going to talk about his program, Performance Kitchen and Medically Tailored Meals, and what he's doing in this space. As you guys have heard in the first few sessions, Dr. Rob is the only chef MD I know. He's in New York City. And then we have Gloria Carter, who works directly with the community, the Latino community. She's been doing some curriculum that I've been showing you guys here throughout little small pieces, but she's been fully doing this for a really long time. So I wanted her to give you that experience. And then lastly, we have our amazing researcher, author, Dr. Antonio Miranda, who's a registered dietitian, diabetes educator, and fully well-rounded person who has been researching and specifically Latino health behaviors. So go ahead and go to the next slide. Here's our CME. Again, our objectives. So for those who want to get the CME, go ahead and scan that code. Next slide. All right, so just kind of, you can write in the poll if you want, or just kind of take a minute and think about this. Medically tailored meals. So this would be something that a prescription would need to be written for, right? So if you get a prescription at the pharmacy, or if you get a prescription through your doctor, has anyone heard of medically tailored meals? Maybe you have, maybe it's in the news, maybe you don't know what conditions it covers. You kind of think maybe you know a little bit. Yeah, okay. All right, so some of you have heard of it, and this is great because that means that the marketing world is doing their job. Go ahead and go to the next one. I'm gonna go ahead and let Dr. Rob talk to you about his experience of how this led to being able to scale his medically tailored meal program.
All right. Well, hello, everyone. And as you know, we're 3 hours ahead in New York. So it's 3 o'clock in the afternoon on a Friday in the summer. But I got to tell you the truth, I love being here with all of you. So in the next, say, 10 minutes, I'm going to tell you a little bit about my story and how and why I became a doctor. I really became a doctor because I wanted to help people. I know this sounds somewhat, Hollywood and romantic, but quickly I realized during my training, particularly during my residency, that the people that we were rounding on in the hospitals were in our hospitals, hungry, malfed, both in our hospitals, but also once they go home, they don't know what to eat. It's a very confusing world. And I think the nutrition world, particularly the marketing, makes it very confusing. Today, butter's bad, tomorrow butter's good. Today's fish is good, tomorrow fish is bad. I would argue, if someone recently asked me about what's the worst food in the world, I think trans fats are the worst. If there's one bad guy out there, it's ultra processed foods that contain a lot of trans fats. So in the next, say, 7, 8, 10 minutes, let me just share with you my story. So next slide. So this is where the moment goes, right? And so if you guys want to say it's totally perfectly fine. Right now is the time. That's enough. Thank you very much. There you go. There you go. Thanks, Nelson. So as a little boy, I've always wanted to be a doctor. Why? I don't know. I'm the first sort of physician in my family, but there was also oftentimes you hear about a calling. And I've always wanted to help people. And so as a very young kid, I said to my parents, I want to be a doctor. And it took a circuitous route, but I'm a practicing physician for 25 years. I am board certified in internal medicine, integrative, functional, holistic, lifestyle, and culinary medicine. So there's a lot of stuff that I learned. And I realized that now next slide, after all the training and all the experiences as a physician, what we're dealing with are these things called preventable chronic diseases. And every day I go to the hospital, I go to the clinic, and I realize that if we only had this magic pill called healthy, nutritious foods that we start off our medical paradigm with, we'd probably be a lot healthier as a nation than we are today. So next slide. And so I decided, well, if medicine is not going to sort of teach me about food, why don't I enroll in culinary school? And as Dr. Angie mentioned, I actually went to culinary school after about 15 years working with a culinary school here in New York, teaching doctors how to cook better or healthier. I am not trying to make doctors into chefs. I'm not taking over any sort of registered dietitians. My whole premise was this. And it was based upon a study out of Canada by Erica Frank. And it basically said this: a physician's own health behavior is the greatest predictor of them counseling their patients about that behavior. So doctors that wear seatbelts are more likely to tell their patients about seatbelts. Helmets, more likely to tell patients wear helmets. And so I had this idea, if we're more likely to cook, will we be able to have that conversation with our patients? So next slide. And then this quote changed my life. And I realized this is the problem. People are fed by a food industry which pays no attention to health, and are treated by a health industry which pays no attention to food. So this was my sort of spark that I said, well, I got to start developing and working more in the food space for us to sort of start developing a healthier behavior in our country. Next slide. And why do I care so much? You can fast forward this one here. Because our diet, not cigarettes, not sitting, not drugs, nothing else. Our diet, our standard American diet, is the number one cause of death and disability in the US. Next slide. And we're number one at it. But sadly, what is happening that the world is catching up. So in 2017, the Lancet report basically said this, that 1 out of 5 deaths are linked to a poor nutritional diet. So something has to change. Next slide. And this is the standard American diet. 63% of our foods are processed, as I mentioned before, ultra-processed foods. Think about it. 60% of our calories comes from non-food items. Only 12% are plant sources, and 25% are 12% is plant sources, and 25% is animal food. So this is why we call this the standard American diet, a sad diet. Next slide. And the reason why I put this together with healthcare is it's about time that we start putting our health systems and our food systems together. And our diet quality is the #1 risk factor in death in the US, but also food insecurity, increased probability of chronic diseases, over now almost $60 billion in excess healthcare costs, and also reinforce and exacerbate these inequalities. Next slide. So point blank, I'm in New York, I'm going to tell you how it is. Our food is killing us. Next slide. And our doctors literally don't know anything about this, right? This is a study was published years ago, 2008, but if you did it today, I would guarantee you it's probably the same. About 90% of respondents admitted of internal medicine residents that they felt upon leaving their training, they feel inadequately trained to provide nutritional counsel. Next slide. On top of that, 1 in 3 American hospitals are funded and or sponsored by a large vendor like McDonald's. So 1/3 of all hospitals have some sort of fast food mega restaurant with it. And so I realized this is something that is unacceptable. So next slide. So it's time that we start rethinking and looking at things differently. Next slide. And so this was old timers, right? There's a lot of old timers here. So these are called prescriptions. This is what old doctors like me used to write and give it to our patients. Now it's all electronic. And so this was probably in 2010, maybe. So I started having this crazy idea. What if I wrote prescriptions for healthy foods? Would patients consume them? And this sort of led to a movement by Michelle Nishan called the Healthy Food RX program. Next slide. And as I mentioned before, culinary medicine, cooking with doctors. These are doctors that I took out of a hospital, threw them into a kitchen and teach them how to cook. Next slide. You can continue just for the sake of time. And then I realized that our hospital foods are terrible here in the US. And I realized traveling the world, this is not a US problem. Again, we're #1 at it, but it's a problem that's happening all over our hospitals. And so this is an abandoned rooftop on the top of a hospital in New York City. We had turned from an abandoned hospital rooftop into a flourishing, you can continue slides here, a flourishing urban rooftop garden where we started a movement called Rooftop to Bedside. Next slide. And every single day, doctors, nurses, housekeeping, everyone came out there and sort of shared in a meal. Prepared by some of the fruits and vegetables that we were growing, particularly herbs we were growing and put on rooftop. Next slide. You can continue. And then the chef got involved. And then this is sort of a picture of my wife and I who had this crazy idea about growing our own herbs and fruits and vegetables on the top of a rooftop, which led to a whole green movement in New York City too. Next slide. And I wanted to just sort of change a little bit, talk about medically tailored meals, because our food system is very complicated, it's similar to our healthcare. And I felt that we had to understand it in a full stack approach. We have to understand it from the medical, the education, the retail, the groceries, the culinary, the policy, the insurance, agriculture, and distribution, and ultimately the consumer, right? We have to understand why and where these problems can arise. And throughout my career, I've played in all of these sort of verticals and realized that they're all broken, but they all want to sort of satisfy one ultimate goal. #1, they want to make money, but at the same time, I think altruistically, we want a healthier community. Next slide. And so again, I went back to culinary school to really understand the principles of healthy cooking. Next slide. And so I'm going to transition a little bit into this term called medically tailored meals. So these are actions that are integrate food and nutrition into healthcare. Next slide. Go back one slide. Sorry for this whole thing here. But basically, the slide basically shows you this, is that despite it just sounding good and feeling good, it actually works, right? So when you provide patients either nutritional knowledge, healthy grocery coupons and or prescriptions and or a meal, called a medically tailored meal, we find that these interventions can actually lower your BMI, lower your blood pressure, lower preterm birth, and by extension, lower depression scores. Next slide. And the way I describe this thing is this. And so everyone in our society, right, has this population level of healthy food policies and programs. Dr. Angie and I are very heavily involved in the local, state, national policy, because ultimately, the stroke of a pen is powerful, more powerful at times than the local movements that are happening. But change happens locally first. This led to this movement called WIC programs, SNAP programs, which are still in existence and are always threatened to be discontinued. Subsequently, the way I describe how to prescribe people healthy food is this. You write produce prescription programs. There's a ton of them out there. Also medically tailored groceries, but I believe the tip of the spear, because everyone's confused about what to eat, how to eat, when to eat, is basically a medically tailored meal. Next slide. And so medically tailored meals are meals that are delivered to individuals living with severe illnesses. Now, in today's world, we call a severe illness a chronic disease. High blood pressure, high cholesterol, obesity, to a certain risk of cancer, heart disease, heart failure, almost any sort of disease that you can imagine, right? There has been studies looking at the role of medically nutritional tailored meals for that specific condition. And some of these slides, you guys have it. Ultimately, it does save money. It also improves outcomes and patient and doctor satisfaction, because we as doctors feel that we're actually doing something for them besides becoming the classic 1980s drug dealer or giving a pill for an ill. We're actually changing people's lives by producing and introducing them healthy behaviors like food as medicine. Next slide. And so I just want to talk to you a little bit about a company that I've sort of worked with, and I sort of pivoted their entire book of business from a retail, but retail is hard, right? It has to be taste good, look good, and sell cheaply. But at the same time, that's what we want in healthcare. We also have to design meals that can be delivered to patients who are unable to cook for themselves or just have troubles with their chronic diseases. So this is where we come in as a Performance Kitchen. So we provide the next generation of healthy, culturally, ethnically concordant meals that are designed for your medical condition. Next slide. And these are our nutritional standards. Nutritional standards for medically tailored meals are not fully developed just yet, but we're moving into this direction. These sort of satisfy the Food as Medicine Coalition standards, but also the USDA and RDA standards. So you are guaranteed a healthy, nutritious, nutritionally dense meal if you consume our meals. There's no artificial colors or flavors. And again, these meals are specifically designed to inspire the Mediterranean diet for patients with diabetes, heart failure, kidney disease, general wellness, and more. Next slide. And there's two types of benefits. One is a discharge benefit and a chronic disease benefit. We focus more on the chronic disease benefit because if you think about this, after discharge, you have a hard time getting food onto your plate, partly because you're sick or bedbound or whatever happens. But you're able to give, most insurance companies have a benefit that offers anywhere between 2 to 3 meals per day. 1 to 3 meals per day for 2 weeks. And now, as someone who's a culinarian, we can eat almost anything for 2 weeks. But when really trying to change patients' behaviors, you have to start developing healthy, nutritious, delicious foods. Again, delicious foods that we want to eat, not have to eat. And that's where the chronic disease benefit really is the magic bullet in our healthcare delivery. So our company called Fresh Medicine, where I see patients today, we start with a food-first approach. Here is a diet. Here is a registered dietitian, and here are your meals you need to eat for the next 3 months to be healthier. Next slide. And guess what? Most insurance companies have a covered benefit. So I urge all of you today to go to our website and put in your name and zip code to see if there is a medically tailored meal benefit in your geographical area. We've done the back end of our company has basically a technology company that has sort of gathered all insurances companies and matched them to all zip codes. And so it's simple. Name, zip code, identify the insurance company that has a covered benefit. Just in your geographical location, there is a ton of benefits, guys. And so encourage your patients or yourselves to go to this website, put in your zip code, and find what insurance companies today offer a chronic meal benefit. Next slide. And so all my talks, I like to end with this. In today's world, we have a big epidemic of chronic diseases that are reversible by producing a food-first approach. I'm not taking away your drugs. I'm just adding more healthy, nutritious foods. But at the end of the day, what we truly want in life is to be happy. And so this is my prescription to all of you. So when it comes to food, eat more plants. You need to find time to relax, 10 minutes a day. Exercise 30 minutes a day. Sleep, aim to 7 to 8 hours a night. And happiness is based on positive psychology. Other people matter. It's not the money, not the fame, not anything else, but the people you're surrounding yourself. So I'm really happy to be part of this tribe. And I look forward to working with all of you in the upcoming months and or years. Thank you so much, guys.
Thank you, Dr. Rob. That was amazing. And I've already told patients about this, and we're getting our team on board with this. So next slide. The next thing, so let's just say, like Dr. Rob said, someone has a chronic condition and they're getting this food, but then they don't know how to decide how to cook with healthy food. So you go to the doctor's office and then they write you the prescription for a medically tailored meal. But then you're interested. You're like, okay, well, now that I like this food, can I make some of it to subsidize some of the meals that are coming from the, medically tailored meal? Or when you graduate from the medically tailored meal, can you learn how to cook yourself? So does anybody know, this poll question. Okay, she missed this poll question. What a teaching kitchen is. You guys can type it into the chat and go ahead and go to the next slide. So teaching kitchen is exactly, and then also let's go a little bit further. Does anybody know what a shared medical appointment is? These are terms that they will become mainstream at one point in all of our primary care, in all of our specialty clinics, in medicine in general. This is what is needed to really scale up our patients' health. Okay, go ahead and go to the next one. Okay. Well, let me introduce a little bit of my story and how it all started. So like Dr. Rob said, culinary medicine, we were tired of writing prescriptions. We sort of came into it from the Latino perspective, right? Where you go to a nutritionist, your mom's making you healthy meals from the garden, your grandma's getting herbs from the garden. And this was ingrained in our DNA that we've always combined medicine and food together. And so culinary medicine is really just blending that art of food and cooking with that science of medicine. And we know that it's evidence-based. but it's also going that extra step. So maybe it's reducing the medications. You start introducing vegetables, food, certain techniques to make it safely, to make it more delicious. This helps with food insecurity. You know, can we choose meals that are or ingredients that are a little bit more affordable for patients? This improves the food frequency and the cooking frequency and the skills. People become more confident in their shopping. And this, we know, more meals at home, more time spent with those meals at home really does help improve a patient's health outcomes. So we see this in diabetes, we see this in hypertension, we've seen this in mental health because of the mindfulness piece, and then it's also connecting. And so when you ask me, well, why did I decide culinary medicine? And I have to say, as a family doctor, food is so connecting, right? It is what we pass on when we go to our family gatherings. It is what we pass on with recipes to our grandchildren. It is what brings everybody together. So to me, when I see what is the best bang for my buck to give my patient right now, it's to teach them these skills so that their kids can break the cycles of these chronic conditions that we are seeing up on a rise. Next slide. And so what's the big deal about food? Why, Dr. Neeson? Well, I know it's because it's prevention, but it's also optimizing. It's what we do 3 times a day, right? It's delicious. It's connecting. It's what we pass on. And again, we've talked about our blue zones in our 3rd series, so you can check that one out. But it's linked to longevity as well. Next slide. And so when I explain how do I do this? So are you going to start cooking with patients, Dr. Neeson, or what is this like? So a teaching kitchen, think of it as sort of a concept, right? So it's a concept of where you're teaching and educating, but you're also learning from the participants. So there are times they do certain things in the kitchen and I'm like, oh, I didn't think about that. And it's a back and forth of connecting, but also kind of guiding the things that we know that help improve health. And so it's something that you can do at a YMCA, which I have done. It's something you can do in a restaurant, which I've done. It's something you can do with colleagues. You can do this with community members, retirees, veterans. I've done it with doctors, and Dr. Rob has also done it with doctors. But it's basically leading this movement into how to bridge the two together. Next slide. And so this is what it sort of looked like for me. It's, you know, I've done demonstrations and food demos with the doctor's kids. And so we had another doctor who took the adults and the physicians, and I took the kids, and the kids were learning alongside me. And I can't tell you how many times their colleagues tell me that their child has learned one thing from me and has taken them all these years. And it just gives me such joy because they remembered something I said. I go to lunch demonstrations, to workplaces. I bring people together by doing a cooking demonstration, taking questions and answers. I've gone to a YMCA and just fed anyone from 2 years old to 18 years old and showing all the cooking skills for a family. I've done it in a pandemic, had to shift online. So did lots of webinars, especially for physicians, because I felt like we were getting all these questions of patients at home on how to be healthier. And I was, you know, helping them along. We did outside events once COVID opened, still at night with lights. And then of course the hybrid option right at the bottom. So I started doing some where people felt comfortable online and some still in person. Go ahead and go to the next slide. And I do feel that we've said this many times, but building social connection is really the most powerful thing. And the reason why I love teaching kitchens and the ability to bring people together is that we know that there's research that shows that bringing people out of that social isolation, it really is associated with decreasing the overall healthcare cost. So if we're really looking at it as to how do we tackle these enormous costs that the US has compared to other countries, and we haven't made a dent in our longevity or our health, it's because we're lacking some social connection. Go ahead and go to the next slide. So one of the things I've introduced to my medical group is something called a shared medical appointment. And like I said, this is going to be something that's mainstream at some point. And I would urge you to kind of take a look at your own doctor and ask them about this, because this is going to be mainstream. It's going to tackle anything from conditions that would benefit from a lifestyle modification, you name it, anything. And then you take it from there. And then there's other things. Maybe your GI doctor can help you with your IBS. Maybe you can do it in a shared group appointment with other people. So this was me. We were just chopping away, and I was explaining things, and the patients enjoyed it. They learned something from this session, and we all had and shared a meal together. And so this was an appointment. I had 12 patients in a room. Instead of each individually having one single appointment, we just combined it all. And everyone had the same question, and everyone was able to help each other out. And so it was really nice to be able to come together at the end and say, wow, this was different. There was something there. Go to the next slide. And so how could this look like? Well, it could be virtual now that everybody's open to, going virtual. It could be done with me in the kitchen and the patients in their kitchen. It could be done in person. It could be a hybrid approach. You could invite other supporting staff. So, I could have a dietitian in there with me. I could have a chef with me. I could have a health coach who kind of helps push the needle along. We have plenty of time, right? People always complain about, I never have enough time with my doctor. Well, this would actually help solve that. And we would be tackling those same questions that everybody has without feeling alone. Just imagine your kids are, there's a waiting room of kids waiting to do their physical with their doctor. What if the kids were handling and cooking in the kitchen while they're waited for their doctor, and they were cooking with a chef instead of just waiting in the waiting room? Wouldn't that be such an opportunity? Next slide. And when I've done feedback on patients to see what it is that their biggest takeaway was, it was actually, some people say, wow, I don't know that there's going to be a lot of people sharing, I don't know what it's going to feel like. It's going to be a little bit different. But what people find is that one person who is vulnerable and shares that journey, it really allows for other people to also share their journey and feel that they're seen and that they are not sharing this journey alone. So you can imagine if you had, just been diagnosed with diabetes or just been diagnosed with something, there's someone ahead of you. They know what to go through, what to navigate, what resources you need, what helped them. And so, when we talk about Latino culture, we've always been that way, right? We don't go to the doctor first. You ask your tia, you ask your tío, you ask your neighbor, you ask everybody. And so this is sort of that same way in sharing that community with a shared medical appointment. And this is billable. So instead of billing, a one-to-one office visit, again, you bill it each one, maybe talk a little bit different. You go over each one of them, medications, what specifically would help them, but it's a shared visit. And so it's a billable thing. Next slide. And a real life example, and I don't know if you've done shared medical appointments, but Gloria, if she tied herself to a physician, she could actually bill for it. And the primary care physician or the diabetic educator or anybody else who's there can also help move the needle. And then you start measuring those health outcomes and also making sure that this becomes more mainstream. So I brought her on today. And Gloria, go ahead and talk about your experience with this curriculum called Old Ways, which is the Latino heritage curriculum.
Thank you so much for having me, Dr. Neeson. Yes, my name is Gloria Carter, as Dr. Neeson mentioned, and I am a family and community health agent in Cameron County, Texas, deep South Texas, where over 95% of our community members are Hispanic, primarily of Mexican descent. And what I found as a community educator, promotora, and CHW, community health worker, was that there were no curricula that were culturally relevant to the community members here in Cameron County. And that posed a big challenge and a dilemma because recipes that were being introduced to them were not culturally relevant, not traditional to their traditional diets. Next slide, please. So in comes Old Ways, which is a nonprofit that's been operating for over 20 years, and they developed a curriculum called A Taste of Latin American Heritage. And the key message to this curriculum is that it celebrates the flavors, the sabores, and pleasures of Latin American heritage foods and the ways of eating, which also happen to be exceptionally nutritious. And when we think about a taste of Latin American heritage, they work under what they call a Latin American pyramid. And in this pyramid, you have what the foundation of what Latino eating is about. And it's primarily, first and foremost, is that community, right? Sitting down with tia, tío, abuelita, los niños, everyone together enjoying a healthy meal that, and traditionally they would have harvested themselves, right? And so we want to bring that back, the just eating together as a family. And then as we go up that pyramid, we see a lot of the foods that you would find in the typical Mediterranean diet too, which, like Dr. Graham mentioned earlier, plant-based. So it is a plant-based curriculum. Next slide, please. And so a little bit more about the curriculum is, as a community educator myself, I implement this 6-week lesson plan over the course of, it could be 6 weeks. Sometimes I go twice a week. Sometimes I go once a month, just depending upon the location and the people that I'm collaborating with. But what I have found is that it really is a great introduction to the vibrant history, the culture, and the nutrition of Latin American heritage foods, and we learn how to adapt them to modern life. And as I mentioned a little while ago, it also is a plant-based curriculum that teaches about the foods and how to prepare them. So we have that testing kitchen component that Dr. Neeson just talked about, is that's very vital to our curriculum. So not only do our participants get a lecture portion, but they also participate hands-on in a testing kitchen type of environment. Next slide, please. And so when we talk about Latin American heritage, of course, as I mentioned, Cameron County, we're primarily of Mexican descent, but this curriculum also touches on traditional foods and cuisines that span across Latin America, that include the Aztecs, the Incas, the Mayans, and other Native Americans, the Spanish and Portuguese, and even continental Africans, because we know a lot of the Africans brought in their food to us as well. And these traditions also share many common staple foods and cooking practices that really stem from local agriculture and their cultures as well. Next slide, please. So why is this important? So as I mentioned before, it's very important that our community members, that your patients, right, my students, feel that this is geared towards them. Otherwise, we'll lose them. So that's first and foremost, is that we need something that's culturally relevant so that we can keep them engaged. But most important of all, it's what we eat keeps us healthy, just as Dr. Graham mentioned before. And we know that there's value in eating traditionally and culturally because science, one, has proven the health benefits. And then we know that when there's great sabor, enjoyment follows as well. And I love that this Latin American heritage cooking really relies more on that plant base, as I mentioned before, with whole foods and less on those animal products and highly processed foods that are usually loaded with sodium, sugars, and unhealthy fats. And so what our participants, your patients, will learn by engaging in this curriculum is that the traditional ways of eating reduce their risk of diabetes, heart disease, kidney disease, and different cancers, in essence, chronic diseases. Next slide, please. And so I wanted to share a little bit with you about my population here in Texas and primarily where I live. And this is another reason why a curriculum such as A Taste of Latin American Heritage was so important, is that you'll see on this slide the obesity rates across Texas. And if you'll notice, Deep South Texas, way there in the bottom, we're at 43%, and we're increasing every year. Whereas during COVID, we were 38%. Now we're at 43, and we're only the Lubbock North Panhandle beats us in that. And that in itself is surprising too, because this is recent that their obesity rates have increased. So as you can tell, it's so important that we really reach all these individuals because the numbers are continuously increasing day by day. And yes, Cameron County has a very high diabetes prevalence, Dr. Miranda, you are correct. So all of that, we know with obesity, we have all chronic diseases that follow as well. Next slide, please. So these are a little bit of the class components. Maybe you're thinking about how could you implement this? Well, Dr. Neeson mentioned a little while ago how doctors themselves can do it. Or here in Cameron County, I, as a community health educator, can also facilitate this. Also throughout Texas, we have what we call promotoras and community health workers. They may be called something different in your state as well. Sometimes they're patient navigators, but they work and they know the communities in which they live and they know the people. And so what we do is we go to those local senior centers and parent centers, right, all across our counties. And we do this weekly cooking class / demonstration, and otherwise known as a testing kitchen. We provide them with even online network and resources. And in each 6-week session, we do also request an entrance and an exit survey so that we can get a better grasp on the health outcomes after the 6 lessons have been taught. Next slide, please. So these are some of the testimonials and successes that I've seen in my time of doing this class. And some of the exit survey results have shown that 83% of those who took the class stated that they cook at home 5 or more times per week. Usually at the beginning of the session, we might see 1 to 2, but most people would even put that they never cook at home. So this increase was extremely satisfying and outstanding to me. We also saw that 69% stated that they now eat fruits 5 or more times per week, and 55% stated that they now eat vegetables 5 or more times per week as well. So we're seeing that their consumption of fruits and vegetables are going up. They're cooking more at home, and I'm hearing testimonials about weight loss. And some of the participants will see there that you'll see on the slide, one shared that they learned how to prepare nutritious meals along with recipes that were new to them. And the next person stated that they learned the importance of eating a variety of foods and not to be afraid to try new things. And if you notice that on the slide, I highlighted the word new. In the surveys, I constantly saw that they mentioned new foods. And I thought that was almost like an oxymoron because this is a traditional based diet, a heritage based diet. But that just goes to show you how far removed we are from the traditional ways of eating of our ancestors. And so foods such as pepitas and yuca and a lot of the recipes that are in this booklet have those traditional ingredients of fruits and vegetables and nuts and seeds they are unfamiliar with. They have no idea, they're new to them. So it brings me such great joy to be able to reintroduce them to this. And it brings me great joy also to see all these wonderful successes. So I can tell you that as a community health educator, there are some challenges that sometimes have to be overcome in implementing such curriculum. A lot of the times we do feel that you have to have a willing participant. And so it's really difficult sometimes to get them on board. They're used to eating their tamales, right? Their tortillas de harina with butter. And so it's hard. But the thing is, I encourage you to implement these types of tools and curricula because it's worth it. The health of our community members and of ourselves as well is really important. And even if we touch just one person in our class, that is a success. Next slide, please. And with that, thank you so much for inviting me, Dr. Neeson. I hope that I was able to tell you about a little bit about this curriculum, A Taste of Latin American Heritage.
Thank you, Gloria. You're doing an amazing job down in Texas. We need you. We need more of you. So for those of you who know somebody who's retired, who has that ability to want to do good for the community, join this effort. contact old ways, see how you can become a facilitator, even in a library, even in a YMCA, or, you know, doing it virtually. You can become a teacher for free and really be helping out each other. Some other things that I would like to also make everyone aware of is there's another curriculum that I really like, and I have this in my office. So Full Plate Living, I have their QR code in my office for all of my patients. I have it in the waiting areas. This is another one. They have 3 different options that I really like. One is self-guided. So if somebody wants to start their journey and they want to start it alone, and they just kind of want to dive into it, take a look at some recipes or whatever, that's one curriculum that is perfectly fine for you. It's adaptable to your time whenever you can do it. And then there's another one that if you really were a physician and you wanted to do a small group, just like the one we're talking about with the Taste of Latin American Heritage, you can also do a small group. You can do this within your friend group. You don't have to be a physician. This is actually something that just a high school degree, you could get through it, you can navigate it. And then there's that shared medical appointment model. So if you are a practicing healthcare provider and you are interested in taking that sort of next step, like what does this look like? You can go, and there are free resources. This is a complete free program done with PowerPoint, with handouts, with everything, so that you can start to implement this in your clinic if you wanted to, or have your dietitian implement it. Claudia, the name of the curriculum that Gloria was talking about was Old Ways, the Taste of Latin American Heritage, oldwayspt.org. All right, and then next slide. And then for those of you who want to be Dr. Rob, or you know, have more of a dive into the culinary chefy aspect, this is a fantastic culinary medicine curriculum that was given to the world by my friend, Dr. Michelle Hauser, who I'm going to be presenting with her in the fall at the American College of Lifestyle Medicine. And it goes by week. You know, what do we talk about? Little basic stuff, kitchen, knife skills. What is the difference between sauteing something, stir frying it? But it really dives into, so if you are a physician or you are in healthcare and you're really feeling uneasy and uncomfortable in a kitchen, go ahead and dive into it. Download it for free. Dive in, do it yourself, and then you see one, you do one, you teach one, right? And that's how things go in medicine. And it has all the handouts again, so you can have your students and what you want the students to focus on, but it's fantastic. Next slide. And so moving forward, we want to make sure that we keep research at the forefront. And so Dr. Antonio Miranda, because again, we can do all this work, amazing work, but if we don't actually have a grasp on why we're doing it and show others what the actual metrics and outcomes that we're actually improving are, then we don't stand a chance. We don't prove to anybody. So I'll have Dr. Antonio Miranda go through why the research is important and what opportunities we have.
Thank you. And I'm very qualified to talk about this, not because I'm a great researcher. I'm really not that great of a researcher, but because of what I learned through my PhD. The biggest challenge that we face in research and a lot of times in public health today is that everybody's doing a variety of amazing projects, but nobody's doing them together for various reasons, right? Universities, different medical systems, different compliance and conflict of interest issues. But it's very important, and one of the themes that I want to talk about is highlighting how can we come together and network and do things together so we can go further. So this has been an awesome series, and I'm really happy to have been a part of it. But I want to pretty much bring home and anchor us home before Angie gives our cooking demonstration by giving really 4 ways that we can continue to move Hispanic health forward. So in summary, and I'll go in more depth, number 1, through literature reviews and learning from others. Number 2, through community-based participatory research. What does that mean? We'll talk about it. Connect with others to do more. We'll talk about it, and we can even share some ideas today. And the last one, and the most important one, is knowing your why. We all care about Latinos. We all care about Hispanic health because of our abuelas, because of our mama and our papa, but remembering our why is very important. So next slide. So the first tip that I would give you guys is really practice learning from others, right? Listening to or to Gloria, to Dr. Neeson, to everybody who's been a speaker has even helped me, and vice versa, hopefully. So one of the biggest things we can do is not reinvent the wheel. Another way that we can do that is by conducting a literature review. I know whether it was through your undergrad or through grad school, we were all forced to do a literature review. So the last thing you want to do is go and do one. However, nowadays it's not that hard anymore. Like I went to Google, and remember, the reason you're doing this is to learn what's out there, learn what's going on. I went to Google last night, but I did it years ago and during my PhD, and I looked up culturally tailored programs among Latinos with type 2 diabetes. Well, guess what? Somebody has already done it. You don't have to sit there and sort through the entire literature again. And this is a publication, Diabetes Prevention in the U.S. Hispanic Adults, a systematic review of culturally tailored interventions. Well, what's the takeaway here? You can skim through this and you can extract different themes of, dichos aren't in there, but you can look at the foods that are discussed. You can look at the different programs and how they built them. You can go into the citations. And again, the whole purpose of this is what's been done, how did they do it, and let's stop reinventing the wheel and continue to collaborate. And perhaps the easiest way to do this is attending CE events like today and attending conferences and learning from each other. Next slide, please. One of the most important types of research that many of us know the importance of it, but don't really know the proper name, is what we've heard throughout this series, and it's called community-based participatory research. So if you want to learn more about diabetes in Latinos and the perception of the specific community of Mexicans, of Venezolanos, in Africa, look up CBPR, community-based participatory research, and whatever topic you're interested in, and you're going to be able to read up on people like Gloria, those who have published in PubMed or in the research. So again, so we don't reinvent that wheel. And what community-based participatory research is, it's pretty straightforward. Is we conduct a needs assessment. The prevalence in Cameron County of diabetes, 40 to 50%. So clearly there's a need to do something about the diabetes rate. And then you go out into the community and you start interviewing through qualitative interviews, through phenomenological interviews, and you start giving voice to the community. And ultimately you develop a curriculum or develop a program, an intervention. And this is me giving you the background of ultimately how we create and how we push these interventions and modalities forward is by listening to what's been done and maybe putting our own spin on it and improving on it. A couple of other areas that you can look into is this topic called grounded theory. Notice right here on B, what do I have written out here? Give voice to the community because it should take priority over your voice. True research, that's the essence of true research. Because what I see a lot of times now in research and in people publishing is that they enter a community and say, Latinos are fatalistic, Latinos this, Latinos that. And then they'll ask the community, what is the impact of President Biden or President Trump on your health? When in reality, that's so biased to throw that in there. So there's this concept of when you approach a community, it should be with an open mind. Yes, your cultural background is important, but there's this concept of grounded theory that you should enter on the ground with as minimal bias as you can and open and receptive to what the community is telling you. One example I'll give is I entered my dissertation thinking I'm going to study fatalismo or fatalism among Latino men and what we can do about it to help promote health behavior. Well, what did I find? Well, I'm about to do a publication on it, but it's called The Fallacy of Fatalismo, where I went in thinking there was fatalism, but in reality, the fatalism of solo Dios sabe, of Dios dirá, that's really a deflective technique. It's not a true belief. It's almost just religious slang that we use. And so again, using that grounded theory, unbiased approach is very important. It's kind of like when you approach a patient and we can assume based on they have obesity, they have liver disease, they have diabetes, we can assume what their lifestyle is like, but you don't really know till you meet them. And then implement those changes, conduct those interventions, and then revisit and improve. Next slide. Hopefully I'm not boring y'all too much with the research and best practices that I've learned over the years working with Latinos. And I'm proud to share because I went through some hard times during my dissertation. The reason I bring that up is because anytime you're doing the Lord's work, right? Anytime you're doing work that's for good, it's very difficult. And during my dissertation, I remember I was a young researcher and I said, I'm going to go to the Pulga and I'm going to recruit the 15 men I'm looking for to interview them, and they're going to get $40 out of it. There's going to be a line of people showing up or lining up. There was nobody. They were running away from me. They were like, este quien es, you know, it's very difficult to help the Hispanic community. There's so many barriers externally, internally, culturally, machismo, que dirá la gente, all that stuff. So if you're struggling and you feel burnt out, congratulations, you're doing the right thing. Just take care of yourself. Gloria, I see you smiling. You know what I'm talking about. Same thing with everybody who's an MD or in healthcare. If you're struggling with your patients, you're doing the right thing. So again, the practical steps: connect with others to do more. People will come to me and say, well, what can I do for my comunidad? Well, reach out to Gloria if you have an interest in the Valley. Gloria, do you know of Unidos contra Diabetes? Do you know those guys? Yeah. So that's a diabetes organization for Latinos in the Valley. And again, just looking and finding those other organizations. So if you're looking to get involved, look at the universities and the academic institutions around you. If you're in medicine, if you're a community healthcare worker, look into researchers. People will follow my research on ResearchGate or will reach out to me on LinkedIn because they know by going to conferences and listening to this, they say, oh, that's the machismo guy. That's the valemadrismo, the dichos guy. And so I don't say that because, again, I learned from so many great researchers myself, but one of the most helpful things for me was when I conducted a literature review, I saw that there were only like 10, if not 5 research articles on Mexican origin, Mexican immigrant men. And I found the 2 guys that did that research, and they were so excited to get me involved because we all have a particular niche of care, and you need to find the people that really care as much as you do. So for me, it was Dr. David Orlando Garcia at the University of Arizona. So academic institutions, find researchers, follow them, become friends with them. Now we know that Dr. Neeson, Gloria, all the people on here are super in the know on all these things. Community events, charitable clinics. This is me giving a talk at a community and charitable donation clinic where you can sign up to be a volunteer as a healthcare worker and implement some of these things, and maybe you can go and implement them in your clinic later. Organizations, and of course, the ones that I care about, not the most, but just as much as the students, the next generation. Just don't do it alone. And here are the 2 articles that I've published, and we're working on some fun ones. I'm giving a talk on fatalism and fallacy and the impact of on Mexican health. There's one on valemadrismo coming out. So know what's out there. Next slide, please. And the last slide with the 3 to 4 minutes that I have left is remembering your why. Throughout this series, I've mentioned animo so many times, and it literally comes from the Latin word of life force. And it's a beautiful word if you look into it. But I'll share with you my why, so hopefully it helps you remember or figure out why what your vocation is. My why started with my family and with my dad. People ask, why did you go for your dissertation or for your PhD? And I said, I was sitting there. I went to go visit my parents. I was in their backyard and I saw my dad there with his beer belly and not a care in the world, but unknowingly or knowingly running towards diabetes, running towards a early death and all that stuff. And I said, how do I save my dad? And that's really where it came from, was an area of the population that nobody wanted to help, the machista, the machismo, the valemadrismo, the really hard guys to reach. I said, this looks like a job for me. And if anybody's going to help my dad, then I'm going to do it. And I'm going to help all the guys that are like my dad. And you have to find the niche community that you care about. And the second part is, by learning what my dad's like, I get to learn about your dad, your family. I always share the story of anytime I give a talk, I allow myself to get vulnerable and get emotional, because that leads to a much better experience and a much more authentic experience to the listener. And when I first started out speaking, I spoke in front of students so that I wouldn't get so nervous in front of the conferences. And I remember I would talk about no, el doctor no sabe, yo no voy a ir al doctor, all the things that Mexican men that I learned from them during my research. And a lot of young Latina girls would cry in the chat, I'm crying right now because you're describing my dad. And thank you so much for caring about him, because I thought nobody did. And I care, and I always will care. So I do it for my dad. I do it for your dad. I do it for my niece, who she wants her tato, her grandpa, to live a long time. And the last one I'll say is that before I defended my dissertation, my friend's dad unfortunately died of COVID about 6 months prior to defending my dissertation. And for those who missed the previous sessions, I interviewed the Mexican origin men from the Rancho, low literacy, created a Dichos curriculum, tested the knowledge gain and all that, learned all about male health behavior, specifically to Mexican men. And when my friend's dad passed away from COVID in 2022, right before I defended my dissertation, I lo invité a comer. I invited him to eat. And he said, tell me about your dissertation. I told him, well, it would take a long time. It's 300 pages. And he said, well, give me the 5-minute summary. And I gave him the 5-minute summary, the machismo, the valemadrismo, the different strategies to help the resistance and all that. And you know what he said? He looked at me, and my friend who had just lost his dad 2 weeks ago, and I took him out to eat, he said, Antonio, that's what my dad would have said. And I thought, wow, that's amazing, because I forgot this part of the story. But just before that conversation, I told him, I wish I could have interviewed your dad. He was a perfect participant. I'm so sorry that he passed, but I would have loved to give him a voice. And when I told him the 5-minute summary, he said, well, you know what? That's what he would have said. And a guy who was never going to see his dad gets to live on through my research. So I hope that my experiences and research and the strategies that I've used will help you guys. But ultimately, the most important thing and the challenge that I give you is find your niche, find your why, and if there's work to be done, maybe you're the one to do it. So thank you for having me.
Oh, well, so fantastic, Antonio. Thank you so much. And I have to say that we connected basically like that. I went to a conference on NIH on advancing cultural humility and applications in dietary approaches. And I heard some researchers speak, and I cold called and I emailed him, and then he connected me to you. And we're like familia now. So I feel so grateful that the universe has brought us all together. Your why is so beautiful, and it's just such a remembrance of why we're all here. I was going to go through a cooking demonstration of something from one of the previous curriculums. And then I was thinking to myself, okay, I also want to introduce the concept of the full living plate, because I do like that one. So if you can go to that next slide. That one, yeah. Okay. So the full plate living that I was telling you all about, their concept is that 75%, if we just focused in on fiber-rich foods within that 75%, then the rest of that 25% doesn't matter, right? We can enjoy life, but that 75% is really should be fiber-rich foods that keep us full. And we know that that's good for the microbiome. So that's it. So a simple approach. And that's my takeaway. Next slide. And like I said, I have this QR code in my office. You guys can take this, finishing this as well. So today's recipe is basically on that concept. Go ahead and, I don't know if I included the recipe in the next slide. Let's see. Yes, I did. Okay. So this recipe is mine. I thought, I could use another curriculum. I could use a full plate living, or I could just give you something that is near and dear to my heart. And it came from something that, was from my heritage. I really, during COVID, missed my grandma. I missed her so much. I would give anything to have been able to cook with her again, to have my kids see her, to just cherish that time. There was a lot of downtime. So I was thinking of like something sweet, at the end in Mexican culture, we always have like a cafecito and we have a little bit of something sweet after dinner. And so I wanted that something sweet and that memory of my grandma to take me to work when I would be trying to go for something like an energy, just like a little pep of energy, but also like a little memory of my grandma's with me. I can do this. I can do this. And so I developed this recipe, and it's a little chocolate truffle. And so I'm going to show it to you guys today. Let me get my apron on. And again, that foundation is just fiber-rich foods. So instead of using regular sugar, I used what we used to always make fun of, because these are dates. I don't know if anybody has seen dates, but they look kind of weird. It's dried fruit. Looks like this. They come in a package. I see them a lot of times at the international stores, but you can get them without the seeds, or you can get them and you can take the seed out yourself. I like soaking them in a little bit of some hot water so that they soften up. And so that's going to be my sugar. And the reason why I love dates is that they have fiber. Okay, so we're going to be choosing things and making things sweeter. Let's not let our sugar rise so much. So put the dates in there. And I always double this recipe. Always double it, because I can tell you, I've made it so many times and it's gone in like 10 minutes. My kids just eat it up after school snack. I take it to work. It's a perfect breakfast, to be honest. I really like this. And so here's avena. So here's just some oatmeal, just regular whole grain oats. I love cinnamon. So cinnamon, that chocolate abuelita. This is what I'm going for with this recipe. So it's a teaspoon of cinnamon. And then I like showing people what kind of the difference between a dark chocolate chip with cacao versus a simple chocolate chip. So we talk about that. We're looking at like, okay, in that 75%, if we can get more fiber in there, well, the higher percentage you can get to, which is the cacao, the dark chocolate, that's what our ancestors, grew, right? That's what was used as money. It was the cacao. So going back to our heritage, just like Lori was talking about, is really going back to the dark chocolate. So the higher percentage, the more antioxidants, the more fiber, but again, the less sweet. So this is about 72%, but you can use anything over 60% is usually what I say. Sometimes if you're really not used to it, 55% is okay. And then just kind of move your needle up, or maybe do a half and half. So I put about 2 handfuls in here. And then I also like using maple syrup or honey. And the reason for that is, like, again, sugar is sugar. We know that. But these do have some antioxidant polyphenols, and those properties are very good for our health. So we're going to do some 4 tablespoons. Again, I'm doubling the recipe. So it's 10 dates, 1 cup of oats, 1 teaspoon of cinnamon, and then you can use whatever nut butter you want. So the other thing I like to teach people is This is peanut butter, right? It's accessible, it's protein, and it's got fiber. The one ingredient that it's got is just peanuts. That's it. So look for peanut butters that just have one ingredient. You don't need them to add all the sugar and all the oils, like we talked about, the hydrogenated trans fat. You don't need all that. So if you can, just stick to the regular one that just says straight up peanuts. You can also do almond butter if you have a peanut allergy. So this is something that I've done before. Change it around. And it's going to be a cup of this one as well. So just going to put this in here. Okay. Then we use our easy food processor, put this all in here. And it starts to look like this, okay? It's kind of sticky and pasty, and then I can show you I did it ahead of time. Okay, and then I like getting a little cookie scooper or a little mini cookie scooper, and then that way they're all the same size. And what I do is I just press it real hard, and this is my mindfulness, okay? When I'm listening to the news or listening to my kids, this is something that I do in the kitchen. Sometimes they're with me in the kitchen, and then we make these little chocolate truffles, and you know, we're spending time, we're connecting, but it's rolling, it's kind of going through the rest of your day and then just setting yourself up for success. You don't have time to roll all of them. Sometimes I just stick this whole thing in the fridge and I roll as I go. I like do one, make enough for the day, and then I make them, and then I have a plate full, and then that's it. And so the other thing you can do is you can dip these in chocolate or drizzle some chocolate over it, and then sprinkle. I always finish it with sprinkling a little bit of sea salt, because that little bit of salt makes that sweetness come out a little bit more. So good. I hope that you make this. I hope that you take this to your home and you adapt it how you want, whether it's switching out a couple of ingredients, anything that's good for your family. But I really want to thank everybody, all of my speakers, all of the San Bernardino Medical Society and Inland Wellness Network who have helped me put this series together. Thank you so much from the bottom of my heart. This has been an extraordinary 6 weeks of taking you through this journey of something that I've always wanted to put out in the universe, starting from the foundation of my home, the foundation of many of our growing population's home, and how it can start and be beautifully integrated within our culture, and our health, and our food. Thank you so much.
Dr. Neeson, thank you for bringing us this amazing series. You have been just a star on so many levels, and all of the presenters have been so incredible. And we do also want to thank the Ardmore Institute of Health for funding this through a grant. And we also want to extend a huge thanks to Loma Linda University School of Medicine Continuing Medical Education Office for allowing us to work with them to provide CME for our medical providers. So thank you. We extend our hearts and our warmest gratitude to all of you for bringing this to our community and to our partners and our physicians. So thank you all, and we'll keep you posted on our next series.
We have a little bit of time. Antonio and I were anxiously thinking maybe some people had questions for us, and we didn't want to leave it without question and answer. So if anybody has a burning question and they want to put it in the chat, please type it in and we can have a discussion. Yes, this is definitely a very big favorite of this recipe with kids. Curriculum, we talked about that. The charging of the shared medical appointments, I've talked about that. But yeah, you could just talk to your billing coders and they should be able to look at the American Academy of Family Physicians. They have a whole web page created to shared medical appointments. And then the American College of Lifestyle Medicine has a toolkit for advancing and starting shared medical appointments, including giving you a handout and a flyer that you can start putting in your offices. Who do you talk to, how to make a brochure, which conditions. They are very hopeful in scaling this up because a lot of us know we need to get our patients in, but we as Latinos know that what works best is really that community, that connection that's been missing in medicine. And if you want to view all the rest of the sessions, they are all going to be available on YouTube, Inland Wellness Network, YouTube, and they should be coming up if you just put in their Cultura series. Anything else I missed, Allison?
I think you have covered everything. That was just amazing. I'm just wanting to go make those truffles. Try
They're so
one.
good. Yes, here you go.
Amazing. Yeah, thank you. Perfect.
All right,
Actually, yeah,
thanks everybody.
Yeah, thanks everybody. Thanks again, Dr. Neeson.
Bye.
Have a great weekend, everybody. Bye-bye.
Bye, everybody.